Our next speaker is Associate Professor Batool Nadim. Dr. Nadim is a consultant obstetrician, gynecologist with extensive experience in all aspects of women's health, fellow of the Royal Australasian College of Australia and New Zealand College of Obstetricians and Gynecology. Additionally, she has complete 2-year fellowship, advanced laparoscopic gynecological surgery, obtained subspecialty in obstetrics and gynecology, ultrasound from the Australasian Society of Ultrasound and Medicine in 2018, and a member of the International Society of Ultrasound Obstetrics and Gynecology. Has a PhD from the University of Sydney and an academic lecturer at the University of Notre Dame. Batool has extensive knowledge, experience, and specialist skills in managing a range of issues related to women's health, including pregnancy, childbirth, and has special interest in chronic pelvic pain, endometriosis, and tertiary level scans. Currently working as a visiting medical officer at Hawkesbury Hospital and Nepean Hospital, where I sort of crossed paths with her, and Norwest Private Hospital. She's committed to excellence in healthcare and passionate advocate for women's health. She values women's knowledge and skills and their right to make informed decisions about their health concerns and their management. Thank you.
Thank you, everybody. Thank you very much for the organizing committee to invite me to talk today in this meeting. I have the pleasure to meet all of you and meet my colleagues, friends, and meet new people from all parts of Australia. Now, I know it's afternoon and I know everybody is really feeling tired, so I'll cruise through very quickly. Now, my topic is Polycystic Ovarian Syndrome. This lecture will encompass whatever we've been talking about since morning. We're going to touch on all aspects of medicine in this one. I'll be very quick and just emphasize the important parts. So Polycystic Ovary Syndrome is very common. It affects 8 to 13% of reproductive age group women. But unfortunately, around 70% of these women are underdiagnosed. The reason for that, because it presents differently in different ethnic groups, and also it presents differently in high-risk groups, especially indigenous women, where the prevalence and the complication is higher. All these lovely ladies have polycystic ovary, and you know each one of them is presenting in a different way. Now, as I said, this lecture encompasses all what we've been hearing since morning. So how are we going to navigate this lecture? We're going to talk about the feature, how to diagnose, why it is important to diagnose it, what are the steps to diagnose it, how do we screen for it, and the management. I'll touch very quickly on it. Now, as you are aware, Polycystic Ovary Syndrome, it comes, like the origin of it encompasses multiple origins, where there is genetic factors, neuroendocrine, metabolic, environment, and steroidogenesis. We'll not elaborate on that. I just wanted you to realize that there is no one reason, there is multiple causes. Usually, polycystic ovary present with features. The reproductive one, obviously, the irregular cycles, hirsutism, infertility, and pregnancy complication. Metabolic presents as insulin resistance, type 2 diabetes, and cardiovascular risk factors. And less looked at is the psychological anxiety, depression, and body image. Why it is important to look at polycystic ovary syndrome? Polycystic ovary syndrome is not only gynecological or obstetric problem. It imposes major health implication to the women's health. One of it is the obesity, and we had an excellent session on obesity today morning. So in polycystic women, the prevalence of obesity is higher than general population. The rate of weight gain also is higher in polycystic ovary syndrome population. And also it has a genetic predilection. And also when we look at in general population, the temporal increase in obesity is much manifest higher in the polycystic population. The rate of weight gain in polycystic women is higher, where we can see that when they did a population study, looking longitudinally on the rate of weight gain in women, the women with polycystic ovary, they have 2.6 kg higher rate of weight gain than the general population. Most importantly, that the weight gain starts early from adolescence. And this is where comes our impact, is we need to diagnose properly so we prevent that from this young age group. The most important indicator of the weight increase is the progressive increase in waist to hip ratio. In women, in general, there is two timelines where we look at that, is between 20 and 25 years old and 40 and 45 years old. The psychosocial impact, which is less acknowledged by us clinicians, most of these ladies, they have negative body image and weight stigma, almost a third of them. They present with eating disorder and they have psychosexual dysfunction. The rate of diabetes in polycystic women is also high, and then from this slide you can see that there is almost 2 to 3 times increased risk factor in diabetes and insulin resistance and in impaired glucose tolerance. Risk of obstructive sleep apnea also is higher in ladies with polycystic ovaries. We could see that it is 10 times higher in polycystic women, and also in subgroup of women where the BMI is high, then even the mild sleep apnea is 7 times higher. Cardiovascular risk factor is also high, where there is 1.68 odd ratio. And not only that, but recent study has showed that male relatives of the female with polycystic ovary also have higher risk factor for cardiovascular diseases. So in the fathers, there is 2.3-fold increase, and in the brothers, there's 3.9 increase. And that emphasizes the importance of screening. Unfortunately, there isn't adequate data to look at the women, so you males, be careful. Endometrial hyperplasia is really a risk factor because it imposes the woman to risk of endometrial cancer. So there is an odd ratio of 6.01 increased risk of endometrial hyperplasia and endometrial cancer. Now, everything I'm going to talk about is coming from this guidelines, which is an international evidence-based guideline, and we follow that for screening and diagnosis and management of those women. How do we diagnose polycystic ovary? The typical polycystic ovary, which was prescribed earlier in 1935 by Steen-Leventhal, was infertility, amenorrhea, and enlarged ovaries. And this started from long back ago, from 1721, where that was the first ever described polycystic ovary in an infertile married woman with big ovaries. Now, the criteria to diagnose polycystic ovary has changed over the years, and what we follow now is the Rotterdam criteria from 2003. Basically, we need 2 out of the 3. Ovulatory dysfunction, hyperandrogenism, whether it's clinical or biochemical, and the polycystic ovary morphology with exclusion of thyroid disease and hyperprolactinemia and the adrenal hyperplasia. Now, I wouldn't talk much about this slide, but this is just tells you the difference between when we first started to diagnose and the one. Before we needed all of them, now we need 2 out of 3. So a woman may come with ovulatory dysfunction, hirsutism, but normal ovaries. A woman will come with ovaries, ovulatory dysfunction, but no androgenism. Or come with hirsutism, hyperandrogenemia with polycystic ovary, but normal ovaries and ovulation. Sorry, normal cycle ovulation. What we need to be aware of also is the ethnic variation in the presentation. It presents differently in different ethnic groups. So we need to be aware that severe hirsutism is common in Middle Eastern, Hispanic, and Mediterranean people. Also, central adiposity is more common in Southeast Asian, indigenous Australian. East Asian have lower BMI compared to their peer group, and also higher BMI is also more prevalent in African. So the way we look at it differently in different people. Let's define what is ovulatory dysfunction and irregular cycle. The guidelines tell us we should not label a woman having irregular cycle unless it is 1 to 3 years post-menarche, if that period is less than 21 days or more than 45 days. If the woman is 3 years post-menarche to the area of perimenopause, then look at the number, it's 35 days, not the 45. Or if she presents with less than 8 cycles per year in this age group, if the woman has come 1 year post-menarche where she has a cycle 90 days apart, only one cycle, or if she has primary amenorrhea by the age of 15 or 3 years post-terlaki, that's where is the breast developed. Now we'll have to be careful in the group of adolescents. You cannot imagine how much psychological impact you put on a girl, 15, 16 years old, and you tell her you have polycystic ovary and she grew up with this one. Like, it really destroys their life. When they reach their 20s, they are really distorted body image, they can't have relationships, and they are withdrawn from the society. So we need to be careful in this age group. In this age group, how we diagnose polycystic ovary with the symptoms, irregular cycles, we'll have to be careful. We'll have to wait till 8 years post the puberty. During this time period, we keep on monitoring, During this period, we keep on monitoring. We just don't say, no, you don't have it, go. We keep on bringing them back for monitoring, asking about symptoms, and I'll show you the frequency of monitoring later on. But we keep on looking after them till they finish the 8 years, and then we are certain of the diagnosis. Please don't label them polycystic till then. I have seen people 11 years old and they tell them you are polycystic ovaries. Now, depending on the regularity of the cycle is not a definite thing, because we still could be anovulatory with regular cycle. If you are in doubt, if you see that this girl had other symptoms and you want to test for being anovulatory, do serum progesterone. Now, what do we mean by clinical hyperandrogenism? We said hyperandrogenism could be diagnosed by symptoms or clinical or by biochemical test. So what do we mean by clinical? Clinical is really hirsutism and acne. And even with that, we need to be careful. We need to have a scale to measure what do we mean by hirsutism and acne. And you spoke about obstetrics in your lecture, Dr. Ziad. I'm going to speak about dermatology in my lecture. So hirsutism is defined by increased hair, and we use the modified Fuhrman-Galloway scores to indicate how bad is hirsutism, and usually levels above 4 to 6. And this is how does it look like. So it divides the body into areas, and we look at the hair in these areas. Alopecia is another part of hyperandrogenism, and we use the Lidwig alopecia scale. Acne, there is no scale to measure acne, but if anybody comes complaining of bothering acne, then that is significant. Biochemical assessment, as we are aware, is measuring the blood, and we should be careful with the reference because each lab has its own reference. And if the levels are so much higher, then we look for neoplasia. We measure free testosterone, free androgen index, and calculated bioavailable testosterone. Be careful with the DHEAS because it's not specific. And we cannot measure these hormones if the woman taken contraceptive pill. She should stop it at least 3 months before measuring it. Now, does polycystic ovary happen in menopause? Yes, it does. It's not having menopause. You don't have polycystic ovary. It's just been masked or missed. And those people who go to menopause with polycystic ovary, they go to menopause later and they have more hirsutism. The anti-millennial hormone is a new trend. Now everybody is doing it, and we know that it's high in polycystic women, but it should not be used as a diagnosis for polycystic ovary. It does change with age. And if the woman was taking hormone contraception or she had a surgery on her ovary, and it does vary with the body mass index too. Now the ultrasound, this is important because the ultrasound definition of polycystic ovary has changed. Nowadays we have a newer ultrasound machine, very high resolution. We can count the follicles. And counting the follicles, it should be more than 20 follicles or ovarian volume of 10 ml. Older machines, they cannot measure the follicles, so we depend on the volume, 10 ml. And counting the follicle is in all around the machine. If it is only in one side in 2D, it should be more than 10 follicle per session or per, what do you call it? Yeah, per sorry. So that's how the polycystic ovary look like. This is the newer machine where you can see it is calculated all of these follicles in one go. Screening, as I said, that polycystic ovary is coming with so much impact on the woman's life. So we should not only diagnose and that's it, we should bring her frequently for screening. One of the things which is missed is the quality of life. These women really are impacted psychologically, so they are withdrawn, they don't go out, they are worried about their body, and they don't have relationships. So we should screen them for quality of life with this. This is proposed by the guideline, which they call the PCOS quality of life tool, which is questionnaires. We should also scan them for anxiety and depressive symptoms, psychosexual problem, and eating disorder, which is not usually a common practice, but they do come with eating disorder, so please screen for that. Weight assessment, it should be in a minimum every 6 to 12 months. We do the waist-hip ratio. For endometrial cancer, there is no guidelines when to screen for it, but if the woman is symptomatic with bleeding, then we'll have to do minimum ultrasound and endometrial biopsy. But just to screen, like we bring her every year for ultrasound, is not indicated. Cardiovascular risk depends on the woman, her body mass index, and if she has hypercholesteremia, then the frequency of doing screening for cardiovascular risk depends on the risk factor, but every woman should have a baseline cholesterol and lipids, and measuring blood pressure annually. For diabetes, it's advisable to do it every 1 to 3 years with a formal oral glucose test. In pregnancy, as you are aware, we should do oral glucose test prior to pregnancy, and if a pregnancy, before 20 weeks. Now, I know my time is finished, so I'm going to stop here. But if you want to ask me about treatment and everything, we'll do it later on. Thank you very much.